Great. Good afternoon, everybody, and welcome to this Sunday session of Coblation organized by Smith and Nephew. My talk would be Coblation in CSF leak repair. I would not go into the details of the anatomy of the Coblation wand, but as Dr. Boonsam has already beautifully shown you, that there are a couple of advantages of the wand which we will be discussing in the panel later on. But that being said, number one, low thermal damage. Actually, the temperatures are much less when you use monopolar or bipolar instrumentation. Secondly, the malleability of the wand. As Dr. Boonsam had shown you that many times the bipolar forceps will not go high up in the skull base. It's not easy to use. And all of us have struggled with opening the bipolar forceps inside. Even with specialized bipolar instruments, it is not always easy to use them. But with the Coblation, it can be easily bent, made to shape, and enables us to reach hard to visualize or reach areas. So I'll go ahead with my talk. I am Ramandeep Virk. I'm an ENT surgeon at the Postgraduate Institute of Medical Education and Research in Chandigarh, India. So basic overview, the talk here is the use of Coblation in CSF. So I'm not going to go very deep into the nitty gritty of CSF leaks, why they happen, what are the signs, and the things we can do to prevent them. So just a basic few slides. How do CSF leaks get closed? No one really knows, but they're probably covered by a layer of fibrous tissue or regenerated nasal mucosa, since dura mater does not regenerate. So after you have plugged the defect, it is the nasal mucosa or fibrous tissue which closes the defect, since the dura mater will not regenerate. Okay, and what is the gold standard test we get done to diagnose? Many times, you can have a clear watery fluid from the nose. It can be a cyst in the maxillary sinus which has ruptured. Even allergic rhinitis can present with, watery fluid. So beta transferrin is the gold standard test. The advantages are it is non-invasive, it is repeatable, sensitivity is up to 99%, specificity is 97%. And it is a protein detectable only in CSF, perilymph, and aqueous humor. So per se, it is the gold standard test. The disadvantage, it is very expensive. At least in India, the cost ranges from anywhere to 5,000 to 25 to 30,000 in some labs. It is labor intensive and time consuming, and expertise is required is very high and takes about 24 to 48 hours to perform. Now, what is the radiological investigation which we all get done? So there are a lot of radiological investigations in the past. They said do a CT cysternography, then an MR cysternography. But one single investigation which has really worked for us in our setup over the hundreds of CSF leaks we have done is a high resolution computed tomography. Very, very thin cuts from 0.35 to 0.5 millimeter cuts. It is the mainstay in the workup of CSF leaks. If it is traumatic, they can diagnose site of fracture. If it is spontaneous, it can diagnose site of defect. It is non-invasive. Sensitivity is 87% in literature, but with the modern machines and modern algorithms, it probably has gone up. Accuracy is approximately 87%. And fractures not always correlated with presence of leak. So that is one of the few things in which MR cysterno or a CT cysternography can be done. So just a basic algorithm. If we have a CSF leak, get a beta transferrin test. If the test is positive, get a CT scan. In case a CT scan shows a defect, it's a single osseous defect, no other imaging is necessary. Unless, of course, it's a spontaneous leak and you are looking for signs of benign intracranial hypertension, like flattening of the globe, tortuous optic nerve, perineural enhancement, empty sella. I mean, those are the things in which a MR cysternography does help. That will depend on the protocol at your place. But otherwise, if you're just going to go ahead and operate the case, simple, do a beta-2 transferrin and then do a thin cut CT, isolate the defect and repair it. Now, if beta-2 transferrin is positive and the CT shows more than one osseous defect and an opacified sinus, CT cysternogram can be done. But CT cysternogram works if there is an actively leaking defect. This is very true in traumatic cases because you will get a thin cut CT, you will see multiple fractures of the skull base because it's a trauma and you really don't know where the leak is coming from. So you just can't go and start closing all the fracture sites, because majority of the traumatic CSF leaks, they stop by themselves. So you do a CT cystonogram, see where the leak is coming from, plug that site. So these are two main things you will encounter in your practice. And if the beta 2 transferrin test is positive, but the CT scan does not show anything, make sure you go back, watch the CT scan on the console. Reading them on films can be difficult because not all the images are printed. And repeat a beta 2 transferrin test. If second sample is positive, CT cystonogram or MR cystosonography can be done. Now I'm going to show you a few videos. Where can the leaks come from? They can come from the cribriform plate, from the sphenoid sinus, in the sphenoid sinus from the roof or the lateral recess of the sphenoid sinus. They can come from the clivus of the sphenoid sinus and the lateral lamella. So these are a few areas where these leaks come from. So the first video is a CSF leak from the left cribriform plate. So we use Merocil to decongest. This is the left nasal cavity. You can see a meningoencephalocele in the skull base. The middle turbinate has been lateralized. Now we are using a ProSize Max Coblation wand. We bend the wand slightly upwards and we ablate away the meningoencephalocele. So once the defect is delineated, then we just pack it up with Surgicel and fat, put a small fascia graft, a drop of glue, and that is it. We don't even pack the nasal cavities. We always use fat which is wrapped in Surgicel. The reason for that is prior to a few years ago, I was using isolated chunks of fat taken from the thigh. They are very difficult to work with, and especially in defects of the cribriform plate, because the leaks are very, very small. With Surgicel, it is easier to push the fat into the defect. Then take a small piece of fascia lata, and in case the space is narrow and you don't want the two parts of the fascia lata coming together, we can insert a small piece of Surgicel over the graft and we cover it with a drop of glue. So we use fibrin glue, and a few drops of fibrin glue is all that it takes to seal this repair. And that completes the procedure. Now you will see how there is a lack of bleeding. This is only possible because of the coblator wand. There is a lot of clarity. You can see the bony edges and your field is absolutely very, very clear. Now I'll show you a leak from the roof of the sphenoid sinus. This was a case, see, now you can see the CT scan which was done. The arrow points to the defect. And you can see an MR cystosonography which was done, which you can see CSF leaking into the sphenoid sinus and a meningoencephalocele present in the roof of the sphenoid sinus. Again, the same procedure. There'll be a ticker running in the lower end in case you want to see that. We go, the corridor, how you will address this leak is very important. Since it is the sphenoid sinus, we can go through the corridor between the middle turbinate and the septum. No point going through the normal middle meatus and destroying all the cells to reach the sphenoid sinus. In this case, it is head on into the sphenoid sinus between the middle turbinate and the septum. So again, we use decongestion, Merocil and adrenaline. We can see the natural ostia. That's the natural ostia. Once that is identified, we use again a ProSize Coblation wand, and we ablate around the face of the sphenoid sinus. A part of the superior turbinate can be resected out very easily in case there is narrow space. That depends upon anatomy. If the space is large, you can leave the superior turbinate intact. If the space is compromised, then you can take down part of the superior turbinate. Once the natural ostia is identified, we are going to widen it. Make sure all the, so it has two modes, ablation mode and a coagulation mode. If there is any bleed which is occurring, it can be taken care away with the coagulation mode. In that mode, all you have to do is press the wand against the tissues for a few seconds and press the pedal. Your bleed is going to stop. Now you can see the meningoencephalocele coming into view very clearly. So ostia is widened and meningoencephalocele is identified. And now we are head on onto the defect. Again, with the coblator, we are going to reduce the meningoencephalocele away. And the advantage of this coblator is that even if the CSF leak actively starts to leak, it will not stop working. Actually, it works better in fluid because it needs fluid in the form of saline, or in case there is a CSF leaking, to produce plasma. So in many times in bipolar, if there is over irrigation, it doesn't work very well. In monopolar, if there is a lot of water or blood, it doesn't work very well. But with the coblation, that is not the case. So you can see the CSF leak and the CSF is actively oozing out, and we are reducing the meningoencephalocele with the coblator. See how beautifully, without any bleed, it is being reduced. Now you can see some of the brain tissue since it was a meningoencephalocele. This is dead brain because gliosis takes place once the brain leaves the cranial cavity and prolapses into the nose. Now I'm working around the defect and removing mucosa from the roof of the sphenoid sinus, because when you have to apply a graft, make sure the bone is bare. That is the defect which has been delineated. These were first few of my earlier cases in which I was not using Surgicel. I took a big chunk of fat and I push it with a ball probe into the defect. Now we use a dumbbell shaped, repair, which half of the fat goes inside, half remains outside. And once the half which is inside, brain and CSF pressure applies against it and it presses it and stops the leak. Facial lata is always kept by overlay technique. In the initial cases, we were, just to be sure, we were also covering with a small piece of Surgicel, though I do not do it anymore and I don't know what advantage we were seeking. A single gel foam is pressed against the defect and no nasal packing is used. Now we will come to defect of the lateral lamella. So lateral lamella is another area. The corridor in which we need to use to address the lateral lamella CSF leaks is the middle meatus. If I try to go through the septum and the turbinate, like in leaks of the cribriform plate, which was the first case I showed you, we will not be able to isolate the defect completely. So you have to go through you have to do an uncinectomy, you have to uncap the bulla, and then you will see the defect in the lateral lamella. So finding your corridor is very, very important in CSF leaks. You have to know that if it is cribriform, you can go between the septum and the turbinate. If it is lateral lamella, you have to go to the middle meatus. If it is sphenoid, you can go through the middle turbinate and the septum. So we have to be very, very clear in the corridors which we are using. So in this case, you will see I don't only use coblation at the defect, but also to perform the basic steps of the endoscopic sinus surgery. And the reason for that we will discuss later on in the panel. So this is the right nasal cavity, that's the bulla. You can see the uncinate, and I am doing an uncinectomy with the help of a coblator. Notice the absence of bleeding. There is not even a single drop of blood. That is the biggest advantage of working with the coblator. It shows me the surrounding anatomy beautifully. There is no bleed, and I can actually teach better because I can show them, my students, all the surrounding structures, how well a bony defect can be delineated and all that. So an uncinectomy has been done and I can see the bulla. Now that is the bulla ethmoidalis. Again, with the coblator, I am ablating the mucosa of the bulla. Again, notice the absence of bleeding because the ablation not only takes away the tissues, it also causes hemostasis in small vessels. So larger vessels, it might not be able to take care of the ablation mode. For that, we have to use the coagulation mode. Once that is done, I'm just going to uncap the bulla using either a J-curate, or you can even use a microdebrider. So I have uncapped it. And it is very important to remove the bulla completely. Otherwise, the leak will not be, the site of defect will not be identified. So I am taking it upwards, the J-curate, to remove the complete attachment. And this is the meningoencephalocele. So as soon as the bulla is uncapped completely, the meningoencephalocele comes into view. So this is the same patient of whose video you saw previously. That is the leak from the lateral lamella. Okay. So I use a lot of decongestion just to keep my field clear, and that is the meningoencephalocele. Now, using again a precise MAC which has been bent about 15 to 20 degrees, I ablate away the meningoencephalocele. And I also ablate away the mucosa around the meningoencephalocele because I have to expose the bare bone for the graft to stick upon. It is very important to remove part of the mucosa around the defect, at least for 5 to 8 millimeters. So if in case there is any other bleed, that can be taken care of with the coagulation mode, like I said. Now you can see the absolutely circular defect from the lateral lamella. So I'm going to, because I'm working very near the defect, I will refocus my endoscope, take away any small bone chips, and see how the dura adheres to the mucosa. Now this step is very important. And see how avascular the cobblator has made the tissues. We have to separate the dura out from the mucosa. It is just like operating or doing a laryngoplasty. We have to separate out the layers for the surgery to be a success. Now you will see here at the lower end, the dura is still stuck to the mucosa and my C knife has removed it. Now again, a fat wrapped in Surgicel is taken up to the defect and I push it in like in other cases, a typical, dumbbell shaped repair. Half of the fat and Surgicel will be inside. And in these cases, which have a flat surface, you can even put a thin bone graft from the bone taken from the ethmoids. So I'm pushing the Surgicel and fat inside. And many times you will find a lot of space to kind of push this fat and Surgicel inside. Once that is accomplished, I take another small piece of Surgicel just to finally seal the defect and push the remaining fat which was bulging out completely inside. Now, once that is done, I will use a thin bone which was harvested from the ethmoids. So once that is gently tucked in, I always have a cottonoid in the cavity over which the suction can be done. Don't try to suck directly over the repair. You will pull the wax and the Surgicel out. And now I'm taking that small ethmoidal bone. The reason I use bone is because this bone is like micromillimeter thin. It is as pliable as a cartilage and it is much thinner than a cartilage and allows us to, manipulate it very easily. And all we have to do is tuck one end into the defect. So I have inserted one end into the defect. And then because this bone is so thin and pliable, I create a notch at the lower end, hinge my sickle knife against it and push it inside. So that has sealed the defect completely. I put a small piece of fascia over it and a drop of glue. No nasal packs will be used because there is no bleed. The field is very clear. The patient is very comfortable post-operatively. So that will complete the procedure. Now we come to another condition which is called a lateral recess leak. What exactly is a lateral recess leak? Lateral recess basically is the area which gets pneumatized at the body of the pterygoid. Normally the body of the pterygoid is solid, but if it gets pneumatized, it creates a lateral recess. I will show you a few scans later on. Again, the corridor I'm working right now, this is the left nasal cavity. This is the middle turbinate. This is the superior turbinate. I'm going to lateralize it and expose the natural ostia of the sphenoid sinus. So with an elevator, I'm lateralizing it. Then using a coblation, I'm going to ablate away the tissues over the face of the sphenoid and expose the sphenoid completely. In defects of the lateral recess, it is mandatory to remove part of the middle turbinate also. So once this ostia is identified using a ronger, I am widening it, and you will see an arrow coming up, that arrow. That is the meningoencephalocele. Now, if I was operating this case through this corridor, I would not be able to reach the lateral part even with an angled endoscope. Many surgeons have attempted that, but the results are not as good when you do it through a transpterygoid approach because of the lack of visibility. So once that is done, I just bipolar away the middle turbinate and snip it off. I leave a stump for an anatomical landmark. You can even do it with a coblator. I mean, whatever you are comfortable with. Once that is done, I'm doing an uncinectomy. Again, the same way as done previously. Again, notice the clean field and the lack of bleeding. I widen the maxillary antrum, and the maxillary opening is taken far posteriorly to make it flush with the posterior wall. Then I am finding the sphenopalatine foramen to take away the sphenopalatine vessels. So I work around this area and we identify this ledge. This ledge is called the crista ethmoidalis there, which is pointed by the arrow. The crista ethmoidalis leads directly into the sphenopalatine foramen. Once that is identified, I've already coblated around that and taken away the small vessels. I start removing part of the posterior wall of the maxillary antrum. You will see these little bleedings here. This bleeding is, see that vessel? These are all part of the sphenopalatine system. Again, they are taken away with the coagulation mode of the coblator. Once that is done, the pterygopalatine fossa is exposed. And now we have to go through this fat and tissue to expose the face of the lateral recess. So once that is, and you have to work between the Vidian nerve and the foramen rotundum. That is the area which is the face of the lateral recess. So I'm ablating the tissues away. I will have to sacrifice the Vidian nerve. You can see the Vidian nerve come into the picture right here, this white nerve. I again sacrifice it. Sometimes a very troublesome bleeder, which is the Vidian artery, which accompanies the nerve, can come along, and that can be taken away with a diamond drill. So you can see the bleeding, slight bleeding, and this arrow points towards the Vidian canal. So with a drill, I open the face of the lateral recess. We use a combination of diamond or cutting burrs, depending upon where we are working. Main work is done with the cutting, and then with the diamond burr, I am lowering and further opening and smoothing this wall. Notice I have not touched the meningoencephalocele till now. I will only touch it once I have full exposure. Now the full exposure is there. I switch on to a 30 or a 45-degree endoscope and see how beautifully the whole meningoencephalocele has come into view. Now I bend the coblator a little, use a 45-degree endoscope, and I start taking away this meningoencephalocele. You can see the brain tissue also. Now the meningoencephalocele is gone, and you can see this defect, which was about 4 to 5 millimeters. Again, using a sickle, we lift the mucosa off like in other cases and separate the dura, which is attached to the mucosa. Once that is done, we again use the coblation to shrink the tissue, and we can see a nice circular defect in the lateral recess. Again, fat wrapped in Surgicel is taken up to the defect using a ball probe. It is gently pushed in, just like in the other cases. Once that is done, again, a small piece of bone taken from the ethmoid or around is taken. And this defect is sealed with that piece of bone. So insert from one end and then just gently push the lower end, and that seals the defect completely. We use again a small piece of facial atta. We can take it directly up to the defect. Make sure there is no curling or folding of edges. Spread it out if the graft is curled, and cover the repair completely. See, there is slight curling on the posterior end of the graft. I am uncurling it. Cover the repair and a drop of fibrin glue on it, a piece of gel foam, wet gel foam to support it, and that will complete the procedure. No nasal packs are used. This area is the maxillary antrum, in case you're wondering what this is. And the key here is take-home messages. This defect would be near impossible to repair through just a transsphenoid approach. This area has to be drilled out for us to do that. So this is a CT scan of lateral recess leak. You can see the defect. Okay. And see, this side is not pneumatized. It is the body of the pterygoid on the left side which is pneumatized. And similarly here, another case in which there is a defect in the lateral recess. Now, this is a very interesting case and my last case. I have a few other cases, but due to paucity of time, we have only about 20-25 minutes per speaker. I would not like to push that. This case was operated outside for a defect in the cribriform plate. The defect was repaired. Patient's leak did not stop. The patient was, again, the cribriform defect was repaired. The leak did not stop. The patient came back to us and we were going to do again a repair of the cribriform plate because the MR kind of showed a small suspicious defect at the class. When we got a thin cut HRCT paranasal sinus done, I honestly missed it, but one of our residents picked it up. There was a defect in the posterior wall of the sphenoid sinus in the clivus, as you can see here. So this was a clivus leak and the patient had been wrongly operated for a defect in the cribriform plate. And had my resident not seen it, I also would have gone ahead and repaired the cribriform plate and again the leak would not have stopped. So there is the defect. This is a sagittal view. And again, we went between the turbinate, same procedure, opened it up and we can see a leak in the clivus. The defect was very, very little. I mean, the hole through which the CSF was coming, but it was coming with great pressure. So we widen the sphenoid sinus adequately so that our tissues or the coblation wand does not get stuck. It doesn't hinder our approach. Okay. So this was, we had gone through the left side nasal cavity. Now I'm using a coblation wand and I am working around the defect. So again, like in other cases, we have to make sure, since it was very, very low, we were having a little trouble in accessing it completely. So we had to bend the coblation wand about 25 to 30 degrees for us to enable us to reach till the lower part. So once the mucosa was ablated away, we palpated for the bony edges. And once that palpation was done, we tried to elevate the mucosa from the defect, just like in the other cases. Once that was done, you can see the pulsations. This leak was very little. There was no way I would have been able to shove in a piece of fat into this tiny leak. I widened it a little. It was scary, but we had our neurosurgeons in the OR on standby. And I widened this leak a little. So see the gush of CSF that came out. Tried to make it circular, working gently in vision and never putting any instrument deep. So once it is circular, now that is an adequate size of defect into which fat and Surgicel can easily go. So here I decided just to use a big blob of fat and see how the force of the CSF pushes it out. And notice how that dumbbell repair, once it is done, how firmly it holds. So I'm gently pushing it and half of the fat, as soon as half of the fat went inside, the leak magically stopped. And I mean, it said magically, but it is, it's technically because of what's happening, because half of the fat has gone in and the CSF pressure is pressing that fat against the dura and the leak stops. So not even a single drop of CSF is coming out. Then again, a thick fascia because the patient was operated 2 times outside. We could not get that typical thin fascia. So thicker fascia, whatever we could harvest from the same side, and again covered with drop of glue, pressed with wet gel foam, and that completed the procedure. This was done through the left side of the nasal cavity. It could have been done through the right side also, because the defect is in the clavus, which is central. So small take-home messages: start with simpler cases, take a senior colleague's help when in doubt. Use of coblation makes the field avascular and delineates the anatomy better. It also helps in better teaching. Make sure the bone is bare, a few millimeter all around the defect. Release dura and use fat wrapped in Surgicel for easier working in that tissues. Thank you very much.
Thank you, sir.
Dr.
Would you like to address the questions by the audience first, or we'll the panelists?
No,
You think we should go to answer? I think we have a few questions. Sorry.
Dr. Wilson, do you want to start the panel discussion? And because some of the questions are also very relatable to the panel discussions, and then we can answer the questions from there.
Yep. Okay. So I see the first question from Dr. Rajit that he asked that do I use a Haddad fab? Yes, of course. Or sometimes okay. So normally what I show you. I do a lot of skull base defects, so I need to reconstruction. The Haddad fab is I think it's very popular now. I think almost all the skull base surgeons use it. If Haddad fab available, I use it. But I use the fat and fasciolata also. But a lot of patients that they lose their fat, the tumor already destroy their septum. We don't have that fat. I can use like a free graft, fasciolata, or like a Dulagen, something like that, and that's gonna help. And if you lie with the fat free graft very well, the cuts will be less. Okay. You do the same thing, Dr. Work also?
Yes.
Yeah.
Absolutely.
I see you use a lot of fat. Fat is very good. I love fat a lot.
Fat is very good. And Haddad flap I usually use when the defects are large. I mean, for small leaks and it's an overkill, I would say.
Yeah. So yeah, I think the same. If it's large defect, Haddad flap and multi-layer, kosher will be better. But if it's small defect, like Dr. Work show, just the fat graft is enough, and fat and tissue or cell is nice. That's really brilliant. That work really well. You cannot believe it, but it's really simple and it's work really well. Okay. And the setting of the coblation and how I use what kind of coblation we use. Sorry, I forget to mention. For the nose job or for the nasal surgery, we normally they have two one that you can use. The first thing is easy view. Easy view is very small and it's very convenient to use inside the nose. But if you have a big tumor, sometimes you need to easy. It's wear off because the tip of it, they have like 3 steps of the of the coblation. They have 3 steps, and it wear off very early if you have a big tumor. So now I prefer to use a precise mag in the big tumor. But if it's a small one, maybe easy view is a good choice. But because easy view is really small and it's move easier than the precise mag. For the setting, how we use it. So default, when you put the covator in, the default is ablation will be 7, and the coagulation will be 3. But if the tumor, so normally I'm gonna start with the normal power first. But if it's the tumor is really sticky, it's really tough, and it cannot move fast enough, we can change to like maybe coblation will be 9. Ablation will be 9, the yellow pedal. And the coagulation, if bleeding a lot, you can less, maximum is 5. It's okay. It depends how the tumor responds with your instrument. What about Dr. Work? How do you use it?
Yes. As Dr. Boonsam said, the default startup is 7 for coblation and 3 for coagulation. Most of our surgeries can easily be done with these settings. It's very rarely, like he said, when the tumor is sticky or you need rapid debulking, that we need to put up the coblation and coagulation settings. Now, many people ask me, why don't you reduce it? Because that will reduce the thermal damage. The reason for that is the data available with Smith & Nephew and the testing when they did showed that at a setting of 5 or 6, the thermal damage is same as a setting 7. So we are not gaining much by reduction in the coagulation and the coagulation settings. Increasing definitely will put up the temperatures, but then you have to reach that fine balance of thermal injury versus rapid debulking or working on a sticky tumor like Dr. Bonsam said.
Okay. And what about the tissue gets stuck in the wound? So normally they have a technique. So when we use the Coblation over the tumor, we prefer to move around. We don't stay on the same pace all the time. We're gonna move around a little bit to it's gonna be suck out the blood, suck out the saline, and we suck out the air. It's not stuck. Okay. The problem is that when we do skull-based surgery, if you have small piece of bone, it's gonna stuck in the wound easily. That's what I don't like it. What about Dr. Work technique? What do you,
Yeah.
do you
So
do?
that's a very valid point what Dr. Bonsam said, that do not stay with the coblation wound at the same spot, because once you stay at the same spot, you will see some charring in the tissues, and that charred tissue is going to clog up your prongs.
Yep.
So a lot of saline irrigation, and in case it does get blocked, the easiest way is pull it out, put it in saline, remove the suction port, have a 50 ml syringe, push forcefully, and usually they come out. And many times, if they still don't come out, we use a small brush that comes with the micro debrider blades to gently remove away any char or tissue that is stuck in the prongs.
Mm-hmm. So I think the next question is your question, Professor Work. From where do you harvest the fat? You do a
So
lot of fat.
we harvest it from the thigh because we are also taking a fascia lata. In case we are not using a fascia lata, then you can use abdominal fat. But since we always use the fascia lata, it is better to go through a small single incision, take some chunks of fat and a small piece of fascia lata.
Mm-hmm. Okay. Yes, it is the same because the quality of fat in the ear, the pinna is really good, and the thigh is really one of the best. It's better the tummy. I think we know that is the consistency of the fat is more tough than the tummy. I think it lasts better. Okay, the next question is for you, Professor Work. They ask that beside the complete butler surgery, what the benefit did Coblation offer when you do performing this surgery?
Okay, so bloodless surgery, as Dr. Payush has said, is one. The other effect, what we have seen is the coblation includes the suction and irrigation, coagulation and coblation all in a single wand. So as the nasal cavity is already very narrow, let's say if I was using a bipolar, I would have an endoscope in one hand, I would have a bipolar in another hand. Then my assistant would need to put in some irrigation with a needle, and then of course a suction to extract away the plume. So we will have 4 instruments in a single nasal cavity. That crowds up the nasal cavity. Your assistant is sure to hit the septum or the lateral wall, cause mucosal damage, which later turns out to be synechia. So there is less clutter because you are using a lesser amount of instrumentation. The third advantage I have found is many times when operating on the skull base or in the lateral wall of the sphenoid sinus, normal instruments have great difficulty reaching there. Even a simple straight suction will not reach the lateral recess. In that case, the wand can be bent gently and can be used as a suction, coagulation, cobblator, and saline irrigator all at the same time. The fourth advantage I've seen is many times your tip of the endoscope gets covered in blood. Normally, you would have to pull out the endoscope, clean it, and push it back again. With this, I just take it near to the irrigation ports of the wand, press the cobblator wand once. There is a spout of saline that comes out. It cleans your endoscope. So I've actually reduced taking out of the endoscope repeatedly, which is much better for us. So these are a few of the advantages I have seen.
Okay. So one more question for you, Dr. Work. So they mentioned that they have some people that try to use Coblation for ethmoidectomy, and they found that the post-op they have like a lot of casting.
Right.
I think maybe more than mecodiabetes or something. What do you think, and how do you deal with that?
Which question is that? Sorry, I didn't.
At about the not the last one, before the last one. Doctor
The
from Dr.
advantage of avascularity while dealing with tumor from the crusting is prolonged postoperatively in the region of axis. Any feedback? I actually feel there is lesser crusting, unless you have taken around a lot of mucosa or other things. Even for I would take the next question also. Can we use coblation in pituitary adenoma? So we use this device in pituitary adenoma surgeries, and we have a comparative study which has been sent for publication comparing coblation versus bipolar cautery in pituitary adenoma surgeries. And one of the advantages it had was lesser crusting and less synechia formation. So maybe, Dr. Ranjit, more of irrigation, don't hold the wand at a single place for a longer time. You can increase the saline flow. Many times the saline flow is not adequate. You have to, we usually wrap a blood pressure cuff around it to kind of give it more flow. Maybe these things can help.
Okay. So the next question, we have some people ask that, can we use coblation in pituitary adenoma? I never use it because normally for pituitary, we want to keep the diaphragm or a large noise intact. So I afraid that if I use it, it can reach to the normal gland and also make the diaphragm or the arachnoid layer tear, and this can have a leakage. That I never use it. What about vessel work? Have you used it?
We have used it in, to remove cyst linings. I had a couple of videos. I mean, because of lack of time, my talk was on CSF. I didn't show those, in which, in a craniopharyngioma or such cases, when that thin cyst lining is around, you can actually under vision beautifully take it away with the coblation. And the nasal part and reaching up to the pituitary, we have used coblation for the last many years. And we have also published this technique in a book which was published by Time Publications, Surgical Atlas of Neurosurgery. And we have this chapter using coblation in pituitary adenoma surgeries.
I have some evidence using coblation for meningioma inside the brain.
Yes.
That case is lead to, the tumor is sit near the third ventricle, and the tumor is really not easy. We use bipolar, it's not move, and then I use coblation. I use laryngeal wand. We adapt. It's up level, it's work really well. I told you it's work really well. I use laryngeal wand put inside because the simple one, the precise mac cannot reach in the third ventricle. I go beyond the optic chiasm, and it's work really well. And it's really safe. I feel it's really safe. It's like if you can use bipolar there, coblation, it should be okay there for my point of view.
Yes,
okay,
exactly my thoughts, Dr. Bunsam. Normally, what would a neurosurgeon use? They will use, in case there is bleed, they use bipolar. And we know that the temperature of the coblation is way less than a bipolar. So if a bipolar can be safely used in, to check small leaks from the dura or intracranially, why not the coblation? I think it's just a matter of time before someone does a study and it gets published and becomes accepted. Right now, it's not accepted as such, but it's a great way of using it intracranially.
Okay, but okay, some question. I have the last question that how safe coblation used intracranially, as I mentioned, that is okay if you can use bipolar there. But what you need to know that the good thing about bipolar is that it's work between the two of it, right? It's work between that, but it's not transmit or allow too much. But the coblation thing is that it can stimulate the nerve and muscle. Muscle can be twitched around, and it can stimulate the nerve. If you have used it near the V3, it can make the jaw move or something. You need to be careful in that. So intracranially, if it's really close to the nerve, I will try to don't use coblation because I think it can stimulate the nerve, and I don't like it. Maybe bipolar is safe, but if it's away from the nerve intracranially, it's okay. I think coblation should be fine. But I told you it's off level. But for my brain, I use it a lot, and I never have complication from coblation. That's my experience. Okay. So they have question that for person work. Okay. Is it possible to predict the need of heart attack preoperatively in the case of CSF leak? Oh, I think, okay. What's the work? You back online? Okay. Hello. What's the work? Can you hear me?
Yes, I can hear you, Dr.
Okay.
Bones. I'm sorry.
They
I'm
have
back.
question to ask you that how to predict that you're going to use hard flap or not in the CSF linear.
Right. Hard art flap basically is very easy to harvest. If you're working on the cribriform plate, there is no issue, right? The only issue is if you're working in the roof of the sphenoid, then you need to decide beforehand whether a hard art flap needs to be harvested or not. Because once you have coblated away the face of the sphenoid and taken away its vascularity, then the only other way would be from the opposite side. So larger defects, definitely, in which are a centimeter or more, you have to use a hard art flap. You can't just put in fat and hope for it to heal. It is eventually going to reoccur. So for large defects, yes, you can take a hard art flap or save the vascularity, go up to the defect. If you feel the need, harvest the flap and use it because it's available right there in front of you in the nasal cavity.
So sometimes I use a less Q flap. We can lift the flap at the back laterally, and we can do like pituitary tumor because sometimes not all the case of pituitary surgery that we need to use a flap, right? So we now in my institute we do the less Q flap on both sides, and if we need it, we can lace it.
Yeah.
So less Q flap is like something that you lace the flap just that the posterior part, but we don't lace at the anterior part, so that we can save the flap later.
Yes.
That's like one of the good choice also. It's proposed by Professor Ricardo Calao.
Yeah.
So okay, Professor Dr. Ward, do you want to answer these questions? We know patinatory coagulation. Can we use coagulation?
Sphenopalatine artery, we use the coblation ad you had seen in the videos. Whenever we are working on the face of the sphenoid, use the coagulation mode, keep it pressed for a few seconds, and the sphenopalatine will safely coagulate.
Okay. So, traumatic safely. Okay. So normally they have question that how long we can observe with the safely from the trauma before we do surgery. So normally we know that the traumatic septic can be conservative, okay? But after a week, if not better, we can do surgery. What about I don't know, what about in your country?
So, I mean, we have even waited till 2 to 3 weeks and we have had defects close. The only risk is the patients have is of meningitis, of course. But the kind of, center we work at where it's a large volume center, sometimes it's not possible to do a surgery, within a week. So normally if the patient is stable, there is not too much of pneumocephalus, we send the patient home, call them back. And you'll be surprised that if you call them back after another 2 weeks or 3 weeks, their defect has already closed. Now, we have had many of these patients come back years later with a defect and they give a history. Yes, I had a trauma. So we have those kind of cases also in which the healed traumatic CSF leaks tend to reopen later on.
Okay. So you send them home and do absolute bed rest at home? Traumatic, we ask them to absolute bed rest, right? So they
yes, and not lift anything heavy, restrict their activity, avoid going out. We don't want them getting, rhinitis or rhinosinusitis and then have an infection travel upwards.
Mm-hmm. We have a question also now. How to take care of the van? So you just keep moving and don't use too much power too long. Okay, when you use a pedal, normally I can use it for a few seconds, 10 seconds, and we stop and we wait and use it again. So if you pedal it like a few minutes all long, it's not good. I think it's not good for the one. That's it. So do you use Coblation to harvest the septal flap or hard flap? I never use it because you can lose a lot of the tissue because it can abrade the tissue. So you can from the flap that this big, when you use a Coblation, you can have this size. It can be changed. So I don't think I don't use Coblation on the hard flap.
Even I don't, because unless I had a wand which has a single electrode like the micro Lenger wand, then maybe it would be different. But we need a sharp cut. So a Colorado needle or a knife works best.
But the small one is going to get stuck, gets obstruct
Yes,
easier.
it's going to get stuck. And plus, it's very long. It's going to be impossible to use it in the nose.
Yeah. Okay. So I think that's our question we have, right? So, okay. So I think now it's
Panel discussion then. I'll just share my screen with the questions.
okay. So the first question, okay, let me answer for you. What the real benefit of the using coblation in the skull-based surgery, and the advantage of using coblation skull-based surgery compared to the other technology. So I think skull-based in the skull-based surgery is, as I show you, its benefit is that it's less bleeding. It's make you have the better operation view, and it's make when you're bleeding a lot, you can sometimes you can accidentally hit to the vital organ or the nerve or the vessel. So the correction is make it you have better view, less bleeding, and the advantage is that it's really good. It's remove the tissue. It's easy. If you use cauterization, you use monopolar, you're gonna cauterize it, and you need someone to help you to suction the mist, and then it cannot remove the tissue immediately. You need to something to take out it. You need how do you cauterize it? You need the forceps, the back leg to take out the tissue. But coblation can do in the one step. It's make our surgery faster, and the healing also. I haven't mentioned. A lot of people say that when you do like nasopharyngeectomy in Hong Kong, a lot of my friends do nasopharyngeectomy with coblation because they found the healing is faster than the monopolar cautery. Less casting is very obvious. It's less casting.
And less fibrosis also post-op.
Less fibrosis, absolutely. The healing is better. Healing much better. And second question, what type of skull-based procedure that I show you? If you want to remove tumor anywhere, I think you can use it. And if you can use bipolar neither, coblation is possible.
Yes.
Yep. Dr. Work, you want something to back up me?
Yes, absolutely. And for that matter, like we were discussing, even the pituitary surgeries, if we can use, bipolar inside in those areas, coblation is again a very good option. And again, lesser clutter, it's malleable, it can be taken up directly up to difficult to reach areas where many times we as surgeons struggle with the bipolar forceps.
So the third question, for beginner, want to use coblation in the skull bed. I think you can start with the inverted papilloma. I think it's really nice. You actually in the maxillary sinus or in the ethmoid, you can use coblation to peel off the tumor and it stop bleeding, and you can cauterize the base of the tumor also, because they have a lot of literature that use coblation and it's to prevent, and the recurrence is really low also. So I think in ethmoid, in maxillary sinus is really good. And when you're getting better with it, when you're used to it, you can use it more advanced in that thing. What about your opinion, Dr. Ward? For beginner?
Yes, and another thing I would like to add here is that it will not stop the bleeding from the bone, because the plasma does not enter the Haversian system. It can stop the bleeding from mucosa, the vessels running in the mucosa, but not from, if you see a bleeding coming from a bone, this is not going to stop it. So we should know beforehand. Let's not waste time on trying to stop a bleed from a Haversian system. And other than that, surgeries, Dr. Bonsam has easily mentioned. What wands should you start with? Now, I've heard many people say start with an EVAC 70. Now, the problem with the EVAC 70 is it was designed to be used upside down in a tonsillectomy. When I straighten it for a skull-based use, the plasma does not reach the tip, and there is a lot of charring and blocking with the EVAC 70. So use a ProSize Maxim, use it carefully, attend workshops, see other surgeons who already are doing coblation, go observe, watch how they use, learn the ins and out of the, of the coblation wand before you want to start using it. But an EVAC 70 when turned upwards does not work very well. because in tonsillectomy, it is used downwards. So the irrigation is down onto the tonsil and it's easy to operate. But when I flick it in skull-base surgery, the saline does not reach the top and it tends to get clogged. At least that's my experience, Dr. Bunsam.
Yep, I think so. I found that the EVAC 70 is too big for the nose, and it's okay if you do binostril working, but one nostril is not working, but it is too big. I have used one time. I don't use it anymore for the EVAC 70. It's too big.
Yes, even I don't use it. I use the Pro Size Max. It's it debulks rapidly. It stops bleed, malleable, and good irrigation.
But for beginner, I think EasyView is really good choice. It's small. It's really easy to use.
Yeah. The easy
last, it's EasyView. Yes, it's really good.
Yeah.
The last question is the last question is that Coblation tip and trick. I think we discussed about that already. So don't use. Yeah. So you have anything?
I want to add one point in tips and tricks. Like I said, the wand is malleable. Make sure when you are bending it, there should be no sharp angulation in the wand. If there is a sharp angulation, some tissue is going to get stuck there and your wand will become useless. So it has to be a gentle bend over the length of the wand, rather than a sharp angulation at one end.
Yes. Yeah, it's bendable a little, not much, right?
Yes.
Yeah, that's a good thing about this instrument.
Okay. Thank you so much, faculties. I'll just launch one last poll before we close and request all the attendees to kindly submit their answers.
So I think it's good sign. It's good sign.
Yeah.
Okay. 50% want to try it, and 50% will, they're keen to use it. It's good.
Yes, I would agree. It's a very good sign. I mean, as long as this whatever we are saying is backed by evidence and data, it's always good to move on to something which is better. I mean, we should not be rigid that no, coblation. I've heard many surgeons say no, coblation will do this, it will do that. It's a new instrument. We are still learning. What we were doing 10 years ago, we are not doing that now, and it's a gradual change. And at least like Dr. Boonsam and me, we have lots of publications on the coblator, which are already in international literature. So if it's evidence-based and backed by data, it's a great instrument to use, I would say.
So thank you so much, faculties. We have reached the end of this session. For the viewers, if you still have any questions unanswered, please send them to your Smith & Nephew representative or email it to Smith & Nephew Medical Education team on the email ID that you see on the screen, and the faculties would be glad to answer them back for you. The recorded version of this webinar would be available soon, and when all necessary internal approvals are in place. I would like to thank the faculties for taking out time today and sharing their knowledge, and more so staying committed towards medical education. I am sure there has been a lot of learning and takeaways for all the viewers that will help improve patient outcomes. Thank you so much, faculties, and have a great day ahead.
Thank you, Smith & Nephew. Thank you, Lata. Thank you, Bhavesh. Thank you, Yoni. And thank you, Dr. Boonsam, for giving me an opportunity to do this with you.
Thank you.
Thank you so much, Dr. Boonsam and Dr.
Yeah, thank you, our team.
Bye-bye.
Thank you.
Bye.
Bye-bye.
Have a good evening. Bye-bye. Thank you. Thank you all the attendees. Have a good evening.